If you're not sleeping well, that's going to wear down your brain even more. Part of it is treating the concussion from a holistic perspective, kind of treating the pain, treating the sleep, because if you get people sleeping properly, you're giving yourself a great chance at recovery from that perspective.
First of all, thank you for coming on again.
Oh, I love it. This is fun.
It's been super fun. Although it's been 2 or 3 weeks since your last episode came out, it's only been 5 minutes because for those of you that are listening at home, we record at least 2 to 3 episodes per recording. And so I want to say thank you to Dr. Patel, a neurologist who specializes in traumatic brain injury, and that's what we're going to talk about today. So what I really want to do is for those who might be listening who have, I mean, we've all knew someone who's had a concussion or have had concussions themselves. It just happens. And from our last talk, you had said that it's not just athletes. Athletes are the ones that really kind of the light shines on them of who has a concussion. But this, like everyone listening knows, can happen to them, can happen to anyone. Slipping on some ice, running for the train and tripping or something like that. So let's talk about traumatic brain injury. What is it? What are concussions? What are the symptoms? What are the medications and the treatments for that? Yeah,
for sure. So as we talked about last time, traumatic brain injury is caused by some kind of external force to the brain, right? And so it can be physical, right? So imagine someone getting hit in the head with something, right? So we talked about that with our athletes, but also, as you mentioned, someone falling and slipping and hitting their head. You know, we talked about it last time with car accidents. That's a pretty common way as well. And then also, again, within our military population, stuff such as blast injuries, right? So IED injuries, those can certainly lead to concussions and head injuries as well. And so, as we talked about, you know, there are physiological changes in the brain that you see with a concussion, but we can't see on imaging yet. Well, right. And so that's what we talked about, how imaging doesn't really help us as much in the earlier settings. And so in my practice, typically I will see patients in the outpatient setting, and usually after a concussion, a patient will have been to either an urgent care or an emergency medicine room, right? Because you hit your head and obviously want to make sure everything's okay. And so I'll typically see them, you know, a couple weeks to, you know, even up to a couple months, depending on how far they're scheduled out with the after effects of a concussion. And so like we talked about with a concussion, you know, there's 5 cardinal symptoms that we kind of look for, right? And so headaches is kind of the main one, and we'll talk a little bit more about that. Vertigo and dizziness, those kind of go hand in hand. So that's the second one that I see. Cognition, so the way that somebody thinks is certain, and you know how memory plays in is one of those as well. And then 4th is mood issues, so anxiety, depression, stuff like that. And the 5th is poor sleep or sleep difficulties, right? And so we can kind of, you know, jump into each one of those if you'd like, and kind of talk through my approach to each one of them. Yeah, I think a hot take that everyone kind of knows about is, and I don't know why this or how this got started, but I think a lot of people understand or think they understand that if they were hit in the head, I think Google says to watch out for vomiting and tiredness. And I think a lot of people think that if they get hit in the head and they don't want to go to the doctor, whether they don't have the doctors available or the stubborn, you know, I could be kind of in that category of being a little stubborn, but think that everything is going to be okay. They are going to watch their symptoms. So what are the dangers of if they get hit in the head, maybe they start vomiting and they say, don't go to sleep? Is there any truth to that? There is, and it really depends on the situation, right? And so I tend to be on the conservative ends of things, so I will always recommend people go to the ER or go to the urgent care because, you know, as we talked about, the vast majority of images, and what I mean by images are CAT scans or MRIs, are going to be normal, right? Yeah. But that doesn't mean that everything is normal, right? Every single one. And so, you know, every once in a while, you will see people that have had a head injury that suffered a brain bleed as a result of that, right? So I believe that actually happened to Bob Saget recently, right? I think within the last couple of years is he fell, and I don't know the story off the top of my head, but I believe he fell in his shower at a hotel that he was staying at, suffered a head injury as a result of that, but just went to sleep normally. And then, obviously he didn't wake up the next morning. So that's why I tend to be on the conservative things, because, I have seen it in which people did not go to get checked out. Mm-hmm. And then next thing you know, obviously, it's too late. Right?
And what's happening there whenever they have that concussion? They think everything is okay. They go to sleep and then they just don't wake up. What happens?
So the worrisome thing about that is that someone suffered a brain injury, right? Because if you hit your head hard enough, you can suffer a skull fracture, right? And so I believe that's what happened to Bob Saget, is he suffered a skull fracture. But, your skull, there's only a finite amount of space in there, right? It's, you can feel it on ourselves. It's bone, right? It's very hard. And so your brain takes up most of that space. Now imagine you introduce in other things such as blood into that finite amount of space, right? Eventually, things are going to start squeezing on the brain, right? And if you don't stop that bleeding, well, that's a medical emergency, because then your brain's eventually going to cut itself off and you're going to die as a result of it, right? So that's kind of the dangers of it. In, going to the ER, again, I know our medical system is very expensive, right? And so costs are certainly an issue, but I always encourage people, you don't want to be that one person, right? In medicine, you don't want to be that statistic, right? And that, okay, fine, 90-something% of people will be completely fine going to bed and stuff like that. But you don't want to be that person that got missed. And that, that could be a life or death situation with regards to that.
Yeah, absolutely. And you had mentioned brain bleeds. What about swelling? Is swelling part of it too, where they can hit their head so hard that their brain might swell? And is that an issue? Or is it typically always like the brain bleed is the more
brain
common?
Bleed within concussion? More of these kinds of dangerous things happen more so with the moderate or severe brain injury, right? Now, I mean, if someone does hit it hard enough, theoretically, yeah, sure, you can have swelling, you can have bleeding, stuff like that. With a moderate or severe brain injury, again, not a concussion, people are obviously going to end up in the hospital just by virtue of everything that's going on. And those are your people think, suffered trauma to other parts of their body as well. But theoretically, you could. But the brain bleed is kind of the one that we worry about, just in case that it's mixed.
And what are the tests that show that again?
That's where you get the image, right? So that's why I tell people, go to the emergency room to kind of get that looked at a little bit further.
And is that MRI, CT?
It's usually a CAT scan. Yeah.
Okay.
Yeah. And MRIs are more often taken in the outpatient setting, just because of, volume within the ER and the quickness of the scan. CAT scans usually only take a couple of minutes at most. And, with a CAT scan, you can rule out a lot of dangerous things.
So let's play to the listener who's wondering if they should go, and maybe they came across this discussion as a deciding factor whether they should go to the emergency room or not. Not a lot of people are real sympathetic to or like going to the hospital. Some people just don't want to go because they might be a little bit concerned or worried about what the test involves. Mm-hmm. Whether, a lot of people say I'm claustrophobic, so I can't do an MRI.
Oh, that's a great question.
So what does a CT scan look like for the patient experience?
Yeah. So if claustrophobia is a big issue, which it is for a lot of people, right? MRI can be a problem, right? And so we will give patients sometimes medications to help them kind of relax through getting through the scan. But a CT scan does not run into anywhere near as much of the claustrophobia issues. The tube is not, you don't have the cage kind of sitting right on your face like you would with an MRI. And a CT scan is typically done without contrast in the ER for head injuries. So again, you'll have an IV started by virtue of most likely being an ER patient, but they won't be injecting you with contrast either. So if you're allergic to the contrast, which some people are, you don't have to worry about that.
And the contrast is the dye that they use for the imaging so that they can see what's going on in the brain.
Right, exactly. And, it's not necessarily indicated within brain injury, so they won't do that. But they will do a CAT scan or a CT scan without contrast, and those are fairly quick. I mean, a couple minutes at most. So you'll be in and out of the scanner almost immediately. And, the cool things that they can look for is, A, it visualizes bone really well, so it can look at your skull and see if there was any skull fractures. But two, it also visualizes blood very well as well. So blood, can be seen on a scan, and you can see, okay, is there a bleed that's pressing on the brain and causing it to go to one direction, which is a medical emergency. Again, far, 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 far less likely to see this with concussion compared to, our more moderate or severe traumatic brain injuries. But that's what you're trying to rule out, right? Because, if someone did suffer a concussion with a skull fracture, theoretically, yes, you can have a brain bleed as a result of it. And it wouldn't even necessarily be inside the brain, it would be outside the brain. And, again, the skull is a finite amount of space. So that bleeding outside the brain, but in between the skull and the brain, is going to be pushing on the brain. And that's a neurosurgical emergency at times. So something that you have to get looked at.
And ideally, they could go to the emergency room. They would have no problems going and seeing the doctor immediately. But let's say some time has passed for whatever reason. How important is it to get to a doctor as soon as possible?
Do you mean like months down the line, or?
I think if, let's say there's a patient who might have hit their head and they want to wait to see how they are doing a couple of days later. Can they still have those symptoms? Could it still be an issue 2-3 days later after the event, or are they in the clear?
Oh, as far as like the symptoms, right? So, most of the bleeding, if it's going to be a medical emergency, it's going to be initially, right? Within elderly patients, for instance, I'll bring that up as an example. And what I tell my elderly patients is, as you get older, your body starts to break down, right? So your heart gets weaker. Well, your brain also gets smaller as time goes on, right? And so when we're younger, our brain takes up pretty much all the space in our skull, right? So a younger person is, if there's a brain bleed there, a younger patient is going to present almost immediately or very, very quickly, because there's only a finite amount of room for that brain to go, right? That blood's going to start pushing on that brain and causing issues. Older patients, for example, their brains have shrunk a little bit as time has gone on, right? And it progressively starts to shrink. So you have a little bit more room in your brain. And so we see this every once in a while. I'm actually seeing a patient with this later this week, in that their brain is a little bit smaller. So, there's more air or free space, for lack of a term. And they fell and they hit their head. I think in chart checking, they hit their head in December. And so their primary care doctor got a CAT scan, and all of a sudden it saw this brain bleed there that's likely been there for a couple of weeks. It's causing some symptoms because of the concussion, but it's not causing like a medical emergency because, where he has to go to the hospital immediately to get that blood removed because, it's chronic, or, it's been going on for a few weeks, and, they're just waiting for the blood to reabsorb. So neurosurgery saw him and they said, there's no mass effect, or it's not pushing on the brain because there's now space in the skull for blood. And so, you just watch him over time and let that blood kind of reabsorb on its own.
Okay, so how frequently do patients with a TBI experience vestibular issues like dizziness or vertigo, stuff like that?
Yeah, it's actually fairly common, believe it or not. And so, we have something called our vestibular system, and the way I like to explain it to patients is it's a system that's responsible for your dizziness, balance, position, and space. And it's actually located on the inside of our ears on both sides. And so if you've ever heard anyone talk about the crystals in the inside of your ears, that's part of the vestibular system. And so you can imagine, because of how outside it is, it's inside your ears, any kind of force could, mess around with that system a little bit. And our body reacts to it by causing dizziness, vertigo, imbalance issues. So the classic patient will be someone that hits their head and then is dizzy anytime they try to do anything, right? Such as like going for walks or running or exercising. And, there's not great medicine that really works for that. Every once in a while, patients will get on something called meclizine, which is good short term. The reason that I don't like meclizine is because it actually slows down your recovery from a dizziness perspective. So the way that you want this dizziness to resolve is you want your brain to learn to compensate for it, right? And so meclizine can kind of help slow down compensation, so prolonging the symptoms. So it may make someone feel great in the immediate term, but it may let their symptoms drag on. What's actually really, really helpful is something called vestibular rehab, and it's a special form of physical therapy. There aren't that many physical therapists out there that do it, but at academic centers, you usually find a couple. At Vanderbilt, we had one, Holly Cawthon, who's great at that. And what they do is they will put you through a form of physical therapy but it's a specialized physical therapy to help your brain overcome the imbalance that's going on. And so that's, a lot of eye movements, for instance, a lot of neck turning, a lot of, they'll put you under a virtual reality thing as well to kind of help your body overcome that. And the way that it overcomes that is by strengthening your brain to kind of overcome that imbalance as time goes on.
Oh, wow.
Yeah.
Yeah. There's a study, a test in our clinic, the VNG, vestibular nystagmus.
That's
such a
VNG
hard,
is the right way to say
VNG,
it. Right?
We'll keep it at that. But a VNG, what they do is they put these goggles on, and they're tracing your pupils. There's a TV screen, and they have a dot that moves back and forth, and these goggles are looking at your pupils, and they're seeing kind of eye movement deviations or problems with the tracking of these dots. And what they're doing is they're leaning you back, they're leaning you forward, they're making you look at these things, they're making you look at these pictures. What's going on with a vestibular system that these tests are actually pulling out to see if there's a problem with the vestibular system?
Yeah, and that's a great question. So audiology is the one that administers the VNG test, and I use them quite a bit as well. It's called a VNG, or a vestibular function test. And so having a good audiology department, and like I was saying at the beginning, it's a team effort, right? So again, you got the physician, but you've also got the physical therapist, vestibular rehab specialist. You've got the audiologist, and so on with all these specialists, and they're very useful. And what vestibular function testing, or VNG, helps you determine is, do they have a vestibular imbalance in the first place, right? Because, if someone's dizzy, well, dizziness is a non-specific term, right? You could have dizziness due to vestibular issues, but you could also have it due to heart issues, deconditioning. There's a bunch of other medical stuff that can cause dizziness, wow. Right? A common issue for doctors in terms of diagnosing is the classic dizzy patient, because there's so many things it could be, right? And so vestibular function testing is useful because it will tell you, A, do they have a vestibular issue in the first place? And then B, if it is a vestibular issue, where is it coming from? So we have two, and this is a little bit more into the medical detail of it, but we have a peripheral system and a central system, right? So peripheral is outside, central is inside. So peripheral would be the vestibular system and the inside of your ears, right? So if you find someone having a peripheral vestibular issue, then it's most likely coming from the vestibular system that's on the outside of your ears, and vestibular rehab or physical therapy works fantastic for it. That's the most common vestibular issue. Every once in a while, we will see a central vestibular issue, and that means central. So it's actually coming from the brain, because there is a central vestibular system. And so that we'll see more often in our patients with a history of like stroke, for instance, or some kind of lesion on the brain. Within the TBI population, we don't see central vestibular issues as much, but we can see it. And that's a little bit tougher to treat. The standard of care is still to send them to vestibular rehab, but that can be very, very difficult to treat even for the best rehab specialist in terms of figuring out how to treat those, because, the issue is coming from the brain. So how do you reteach the brain how to overcome that imbalance, right?
I've got a friend of mine who's a physical therapist, and we were talking about this, and some of the maneuvers he was telling me that they perform on people with vestibular issues may cause dizziness to the point of nausea.
Yeah.
What's going on with a patient who is receiving physical therapy for vestibular issues, and they become disoriented so much that they have experienced nausea?
Well, so the physical therapist, as part of the team, is also working to help diagnose, right? So, before I send someone to vestibular function testing, I'll usually send them to physical therapy first, because, if the physical therapist is able to diagnose someone, then that saves them an extra visit from having to go to the vestibular function testing. So the VNG, or the vestibular function testing, I kind of save for these, for the more cloudy diagnosis in which someone's seen a vestibular therapist or a physical therapist and not been able to be diagnosed. But, as I mentioned, there's lots of causes of dizziness. Well, within the vestibular system, there's lots of different sub-diagnoses that can lead to vestibular imbalance. So a physical therapist is trying to help pinpoint where the lesion is as well with their techniques, and that might be what's causing them to be dizzy and nauseous. And then from there, the physical therapist is able to make a specific therapy plan that can help kind of treat the patient, for lack of a better term, and help them get on the road to recovery. And a lot of this is like a home exercise program as well, right? So they'll give them exercises to do at home. And it's not like a physical, you're going to tire yourself out like running, but it's going to be, you're trying to tire your brain out by helping your brain through these eye movements and getting used to the neck turns and stuff like that.
Wow. So that's really interesting for the TBI patients who might be experiencing dizziness, just recapping that it might be a vestibular issue. And there are things that you can do to, get tested for that, the V&G you had mentioned. And then if it is a vestibular issue, some physical therapy.
Yep.
Moving on to kind of some cognitive deficits. What are some cognitive deficits that a TBI patient might experience afterwards?
Oh, yeah, absolutely. So cognition is very tough, right? And cognitive is kind of like our memory and the way that we think, right? And so diagnosing this is very difficult as well. So we can do some tests such as a MoCA, which is an in-office test that usually takes about 10 to 15 minutes. But, as far as cognition is concerned, I typically lighten it to, I'm going to bring you an example, right? Imagine that you're out on a sunny day, right? And imagine that the sun is your cognition and that's the way that you think, right? And so, before you suffered a brain injury, you're at your brightest, the sun is shining down on you, you're functioning fully, your memory's great. Now imagine what happens when you suffer a TBI as cloud cover coming in, right? And so by then the sun is still there, but it's having a hard time getting through, right? So you're having trouble thinking, you're probably struggling at work, struggling at school, whatever. And so, some of that is due to cognitive issues that you can see, but other things, and people don't realize this, is that there are other symptoms of TBI that can lead to cognitive issues, right? And that's where that cloud cover comes in. So one of the most common things is pain, right? Whenever people suffer a head injury, they're in a lot of pain. So headaches, for instance, right? And so what ends up happening, and what I see in my patients is that whenever people are suffering from a lot of headaches, that kind of wears down on the brain and it doesn't make you function as well as you can, right? Because your brain's just tired all the time from the pain that it's dealing with. And, that also happens in patients that don't have a TBI as well, but within the context of TBI patients. Another thing that can function as a cloud is poor sleep, right? So again, we talked about this earlier where you're in this hypervigilant state and you're not sleeping well. Well, if you're not sleeping well, that's going to wear down your brain even more. And so that's why, from a cognitive perspective, there are things that we do, and, we'll go into those, but part of it is treating the concussion from a holistic perspective, right? Kind of treating the pain, treating the sleep issue. Dr. Geis, who I trained under in Florida, brought up this great point in that she likes fixing sleep the most, or not the most, but initially focusing heavily on the sleep, because if you get people sleeping properly, you're giving yourself a great chance at recovery from that perspective.
Yeah, sleep is
huge.
So important in just everyday physical health. It can cause so many issues if you have a bad sleeping schedule or bad sleeping habits. So that makes sense.
Yeah, and so going into specific forms of therapy that we can do. So there's a couple things. One, again, from a holistic perspective, it's treating everything else, especially in the first couple months, because odds are people are going to get back to normal, right? One thing that can really help people is something called SLP, or speech therapy. And, you think about speech therapy, obviously it's people talking, right? But there's many different aspects within speech therapy, kind of like, within physical therapy, there's a subspecialty of vestibular rehab. Well, within speech therapy, there's a subspecialty of cognitive rehab. And so you work with a speech therapist who will kind of work with you to give you some tips and tricks to kind of overcome the deficit that you're having on a day-to-day basis. That's usually really helpful for a person. Now, if someone's about 6 months out after a brain injury and is still having cognitive findings 6 months to a year even, I may send them for something called neuropsych testing, which, I preface this by telling patients, this is not going to be an enjoyable experience, because what you're going to do is you're going to sit with a neuropsychologist for either half a day or full day. Typically, I send them for half day evaluations. And, they're going to do an evaluation where they're going to, kind of get your history. And then they're going to test your cognition in pretty much any way imaginable that they can, right? And from there, they're going to, compare you to the standardized data and then report, Gil, for instance, is suffering from this, this, and this. And then you can get a better idea of the deficiencies that you are struggling with. A lot of the time, what neuropsych testing will find, though, is that a patient is suffering from something, especially, or they'll find within the context of TBI, I should say, is that a patient is suffering from memory issues, but this is all clouded again because they're still in pain all the time. They're in sleep. So you can't get a valid, how much a person is struggling compared to what they are at their baseline, because until you treat all these, comorbid factors, they're going to struggle. Right. And so that's kind of why my practice is, for the memory issues, obviously, we can focus on SLP or speech therapy. But until you kind of get to the bottom of all the other symptoms, people are more likely than not going to continue to suffer from memory issues. So if you treat the underlying issues, odds are, in my practice anyways, that a lot of these memory issues do kind of get better with time.
Oh, wow.
Yeah.
That's positive.
Yeah. This is obviously within the context of concussion, right? And, if someone has a physical brain injury that's more moderate or severe and you can see it physically affecting the brain on an image, well, then that part is tougher to recover, right? Mm-hmm. But within the context of a concussion, I do find that people's memory does have a good prognosis, and that's why I try and treat from a holistic perspective and treating everything and then kind of focusing on the memory afterwards.
Okay, so wrapping this all up, this has been fantastic information, and thank you so much. It's been
I've loved it. This is fun.
An absolute pleasure talking to you. You kind of wrapping this up, I always want to know, are there any new treatments or testing in the TBI space that you're particularly excited about?
Yeah, so our diagnostics are still fairly stable compared to what they've been recently. The whole thought process is that our MRI functionality is getting a lot better with more Tesla. So theoretically, in the future, with increased Teslas as technology improves, maybe we can actually visualize concussions a little bit better on MRI. We just haven't gotten there yet, but that's kind of an avenue of area that we're looking for. A lot of it, though, is more so data as far as treatment is concerned, right? And, as a neurologist, I focus primarily in the outpatient setting, so I'd stick to that. But, in the outpatient setting, like I said, different types of therapies, different medicines that we can treat. And a lot of them are subject or symptom specific, right? So for headaches, for instance, we've got different drugs out there that work really well. For vertigo, we talked about physical therapy, right? And audiology. For cognition, neuropsych testing, we're seeing how useful that is. So a lot of it does kind of depend on the symptom that we're going with. And, I tell my patients openly, I don't want to come off as a pill pusher or anything like that, right? So, if a patient comes in to see me, I'll straight up tell them, I think you could benefit from this. But I try and limit, how many medicines I prescribe, just because I find the patients are less likely to take medicines the more that you prescribe, right? Because they don't want to be on them. Mm-hmm. But B, if you start multiple different medicines on a person at the same time and then one thing works, how do you know which one is working, right? And so what I tell people is, if you've ever heard the mantra, kill 2 birds with 1 stone or kill 3 birds with 1 stone, a lot of our headache medicines are used for other things nowadays. So I'll give you an example. So venlafaxine is an antidepressant, and amitriptyline is an antidepressant as well. Both of those work really, really well for headaches. So if you're seeing a concussion patient that's coming in with symptoms of headaches, but they're also having symptoms of like sleep abnormalities, depression, anxiety, stuff like that, well, amitriptyline is dosed once at night. You take it for headaches, it can help with that. It'll help you sleep, right? And get you sleeping through the night, and can also help with your mood, right? Now, it can cause side effects, right? And so that's kind of the hesitation with it. But, that's kind of how I try to practice, because, I'm not a big pill person either, but if I have to take it, I'll take it. Yeah. And so, the more that you can minimize, the more you can build kind of that relationship with the patient. And that's kind of how I tend to approach things. And, I also tell people, this is not something that you're necessarily going to have to take the rest of your life. And that tends to make people more open to it as well.
Yeah, that's great. And I think a healthy hesitation to take any medications is healthy. Yeah. And I think asking your doctor, listening to experts like you, and really taking their advice it's invaluable. And it's the reason why you went to school for as long as you have. Right. it's the reason, it's your passion. Right. And I think when people listen to their physician, it only benefits them. Right. So, well, great. And wrapping up for maybe the listeners who have had a traumatic brain injury, either in their family or maybe themselves, what is some of the best advice you can give for someone who's just come off of a hospital stay because of TBI, or they're 20 years down the road? What's something that you could say?
And again, I'm biased as a neurologist, but I think that having a neurologist as part of your team, again, even if you see them once, is valuable, right? The multidisciplinary aspect of this is so huge, right? You need a rehab doctor, obviously a primary care doctor. But having a neurologist, even if you see them one time, right? I see patients all the time that had a TBI 10 to 15 years ago, still have some symptoms off and on. And, we get an MRI and it looks okay. But that provides some reassurance to the patient in that, I may be struggling still a little bit down the line, but thankfully, I was able to see the neurologist. They were able to reassure me, and that can make people feel better. Now, that's not something you necessarily have to do. It's very patient dependent, but I do think seeing a neurologist, and that's kind of where we're trying to go as far as neurology is, we as neurologists have ignored brain injury health for a long time. We've been focusing more on stuff like migraines, multiple sclerosis, epilepsy, for instance, which is great because, that is stuff that all deals with neurology directly too, which is stuff that we should be a part of. But I think as far as brain injury is concerned, I think that's something where the field of neurology in general has not really taken an active interest in. And that's what we're trying to kind of flip towards to where we are taking active interest. Because, it's a brain injury, right? And neurologists deal with the brain. So that's something that I think
it's a common,
it's a very common thing, right? Even if people with a history of concussion recover normally without any after effects, I still think that even if it's just for reassurance, I think it is still valuable for a patient to see a neurologist within the first couple of months.
Because you never know what could happen whenever you're being seen by a neurologist, and maybe they're asking questions you haven't thought of.
Yeah.
And then they order you some testing because of some concerning, things that have happened to you since then, and you catch something. That's the very worst that could happen.
Yeah, and that's part of the issue again is that we don't have enough neurologists that are focused on this. I'm brain injury board certified, but again, that's a physical medicine and rehab board or PM&R board. So again, neurologists, there's only a handful of us that are brain injury board certified. So we're few and far between. But, even seeing a general neurologist, there is value in that for those kinds of things because, again, a lot of what we do is general neurology principles. So anyone who's had that neurology training in the past would benefit from it.
Absolutely.
Yeah.
Well, Dr. Patel, thank you for the work that you're doing in the sports world and in the general population world. We're thankful that you're doing what you're doing. And it's been an absolute interesting pleasure to have you on here and talk about TBI. It's not something that I really know much about.
Right.
And so I'm glad to have you here. And let's have you back on sometime.
Yeah, absolutely. Yeah, let me know. This was a lot of fun. I really enjoyed it. And like I said, always enjoy obviously talking to you, but also to patients.
Yeah.
We love seeing traumatic brain injury patients in our clinics. So,
and I can tell you're a patient advocate too, which is really great. It's really great. Well, thank you so much.
Awesome. Thanks, Gil.
I appreciate it.
Appreciate it.
And we'll see you again.
Awesome. Thank you.
Right.